So here I would like to introduce our honorable speaker of the series, Dr. Bhanu Dev Sharma. He did his Bachelor in Veterinary Science and Animal Husbandry from HAU Hisar in the year 2008, followed by Master's degree in Small Animal Veterinary Cardiology from the University of Luxembourg. During his master's program, he did extensive study on feline heart diseases and congenital heart defects in small animals. He has done certification programs in CT scan, radiology, and internal medicine from European School for Advanced Veterinary Studies, that is ESAVS. He is also an active member of European Society of Veterinary Cardiology. Apart from cardiology, in other areas of interest are diagnostic, imaging, and internal medicine. He believes in team building and teamwork and has been practicing as a veterinarian in Delhi since last 15 years. After founding Max Vets Hospital in 2008. After receiving intensive training in Europe and US, he has developed expertise in interventional radiology and cardiology procedures. His name was inscribed in Limca Book of Records for performing the first pacemaker implantation surgery in India in a dog who was suffering from complete heart block. He is a focused and dedicated vet and keeps upgrading himself with the latest in the veterinary field by attending national and international certifications and courses in various disciplines every year. Let's welcome our young, dashing, and highly talented speaker, Dr. Bhanu Dev Sharma, co-founder Max Vets Hospitals.
Thank you
Welcome,
very much,
sir.
Dr. Vishal. Thank you so much for the introduction. Today, I'll be covering two very important cardiac diseases in dogs, which is mitral valve disease and dilated cardiomyopathy. So, Dr. Vishal, if you give me permission, then may I start the presentation?
Definitely, sir. It's all yours now.
I'll just share the screen.
Sure.
I welcome all the participants. Previously, we've covered the basics of cardiology. We've covered auscultation. We've covered feline cardiomyopathies. Today, in this particular session, I'll be covering the two most important cardiac diseases in canines, which is mitral valve disease and dilated cardiomyopathy. We all come across these cardiac conditions in dogs very, very frequently. So I'll start with mitral valve disease in dogs first. So mitral valve disease, it usually affects small breed dogs, Cavalier King Charles Spaniel, Dachshunds, Chihuahuas, Poodles, miniature pinschers, Cocker Spaniels. These are some of the commonly affected breeds in dogs which are affected by mitral valve disease. Mitral valve disease has this anatomy in which it comprises of the valve leaflets. There is an annulus. There are chordae tendineae, which are these fibrous band type of structures which connect the annulus and which basically connect the valve leaflets to the papillary muscles. And then, of course, there are papillary muscles. So it's important to know the anatomy, when when we are studying about a disease, it is very important to know the basic anatomy. It helps us in diagnosing and then later on treating these infections and diseases. This is just to give you a basic idea, about what changes they happen in the mitral valve leaflets and in the whole structure of mitral valve when this disease happens. So there's collagen degeneration, there is endothelial proliferation, there is accumulation or buildup of mucopolysaccharides, there is appearance of embryonic mesenchymal tissue. This is just to give you a brief idea. You don't really need to remember all these things by heart, but it's good to have an idea of what is going on. So as a result of all these changes in the valve becomes thick. There is prolapse of the mitral valve leaflets. There can be annular dilatation. And of course, in the end, it will lead to subsequent mitral valve regurgitation. So there's backflow of blood from the left ventricle into the left atrium. And over a period of time, the left atrium becomes bigger and bigger. And that is what is going to cause all the resultant signs and symptoms associated with this disease. The clinical signs are common in a lot of the cardiac conditions, which we've discussed previously. So these are signs which you will see in mitral valve disease. These are signs which you will see in dilated cardiomyopathy. These signs I've discussed before. The most common signs would be coughing. Coughing would be due to the compression of the mainstem bronchus as a result of the enlarged left atrium. Exercise intolerance would be again because of the lack of oxygen, because of cardiac remodeling, because of cardiomegaly, because of the hypoxia which is created as a result of this disease. Dyspnea, tachypnea, anorexia, syncope. If you do a chest auscultation, there would be a murmur. We discussed previously about the characteristics of the murmur, about the location of the murmur. I'll be covering again in the slides which are about to come. So my dear friends, any disease, if we follow a step-by-step approach, if we follow a systematic way, then the diagnosis will be accurate. We would not miss out on things. It can't be a misdiagnosis if our approach is organized, if it is step by step. So the first step, you will do an auscultation. If the heart rhythm is irregular, you would be doing an ECG. If there is a murmur present, then we would go in for a chest X-ray. I had mentioned to all of you that the lateral and VD views, both the views will be important. And of course, in the end, the gold standard to diagnose these cardiac diseases would be an echocardiography. The location of mitral valve murmur, it's important to know, because if you find this murmur at this particular location, which is the left fifth intercostal space at the level of costochondral junction, which is the area of the apex beat, if you hear a loud murmur at this location, then be sure about it that it's a likely mitral valve disease murmur. This is a audio clip, so I would request all of you to put the headphones. This kind of a murmur you would be hearing, if you hear a if the dog is suffering from mitral valve disease. I'll play it again. The two normal heart sounds which I had mentioned, S1 and S2. So this is a systolic murmur. Systolic murmur would mean that it would be in between the two normal heart sounds. So this murmur is going to be in between S1 and S2. I'll play it again. Just to give you an idea, comparative study is always good. It helps clearing our doubts. It helps to form our basic concepts. So it's important to compare normal with abnormal. So let me play. So this is a normal heart sound. You can appreciate the two heart sounds, S1 and S2. Now compare this to a mitral valve disease patient. So this is a mitral murmur, which you will hear. Right, so a normal mitral murmur. So why I'm starting with a auscultation, because this is step one, right? Then we move to diagnostics later, but the first step will be an auscultation. So that was a grade 5 murmur. This is slightly louder than that. This is a grade 6 murmur. Right, so the turbulent heart sounds are very clear in this. So once we find the murmur, what are the next steps? The next steps are going to be chest X-rays, lateral and DV views, or a VD view also you can take. Then it will be followed by echocardiography. It will be followed by an ECG if there is any irregularity in the heart rhythm. This is a very important slide because staging of mitral valve disease modifies our treatment. If we know how to stage the disease, we would know when to start the treatment. So stage A patients are those dogs which are at high risk for the heart disease, and there is no disease, there's no actual disease present, but this is that category which has breed predispositions. For example, Cavalier-King Charles Spaniels. So they are all in the stage A category. Stage B is the asymptomatic patient, where there are no symptoms of the heart disease, but you would be able to hear a murmur, right? So stage B is divided further into two categories, stage B1 and stage B2. Stage B1 would mean that the heart is not going to appear enlarged or changed on the X-ray. Stage B2 would mean that the heart would appear enlarged or changed on the X-ray. Stage C would mean that there is evidence of heart failure, which is visible, and treatment is absolutely necessary. Stage D is that stage where heart failure is getting hard to manage and it is not responding to the standard treatment. Stage B2, through this EPIC study, which was performed in Europe, US, this was published in 2017. And after the study came, pimobendan was introduced as a salt for treatment of mitral valve disease in stage B2. So, my dear friends, that would mean that the patient is asymptomatic. The patient doesn't have any symptoms. You hear a murmur, the heart appears enlarged on the X-ray. The stage is stage B2, and you start with pimobendan. So, after the study, the use of pimobendan largely increased everywhere around the world. Chest radiographs, you would see this typical pattern of left heart enlargement. The left heart enlargement would be because of the left heart volume overload in the left atrium and the left ventricle. So you all can appreciate here the left sided cardiomegaly which is there. These are different X-rays, depicting varying degrees of cardiomegaly. There is also, if I can go to the presenter view. So here you all can appreciate the involvement of the lungs, but the involvement of the lungs is secondary to the mitral valve disease, right? So there is a lot of pulmonary edema which has built up. So all these patients, they are in left heart congestive heart failure. Echocardiographic changes, we all need to know what exactly happens in the mitral valve disease, because the echocardiography is the gold standard to detect mitral valve disease. So there would be a severe or varying degrees of thickening of the mitral valve leaflets. There can be either one leaflet which might be affected, or there can be both the leaflets which can be affected. In my experience, generally the anterior mitral valve leaflet is more affected as compared to the posterior leaflet. There can be a leaflet prolapse. There would be, of course, a mitral regurgitation. There would be a volume overload of and the subsequent enlargement of the left heart. So there's backflow of blood from the left ventricle into the left atrium. As a result, the left heart, which includes the left atrium as well as the left ventricle, both will become volume overloaded over a period of time. Systolic dysfunction, well, there's a question mark, but let me tell you all that systolic dysfunction, it happens in the very, very advanced stages of mitral valve disease, and it's not a primary systolic dysfunction. As the left heart becomes enlarged, there is additional stretch on the left ventricular walls, and that causes some degree of contractile dysfunction, but that is only in the very, very advanced stages and chronic mitral valve disease patients. Pulmonary hypertension and secondary tricuspid regurgitation, again, it would happen in the very advanced cases of mitral valve disease. And once these things develop, then it becomes more difficult to manage this disease. So this is just to show you all the thickened mitral valve leaflets. So you all can see the left atrium and the left ventricle, and in between the two leaflets of the mitral valve. And in this particular case, they are severely thickened. This is a comparative study between a normal patient. The mitral valve leaflets, you all can appreciate, they are normal in this video clip. There is no thickening which is evident. The left atrium, on subjective evaluation, it appears to be normal. The left ventricle appears normal in size. There is no volume overload. Now compare this to this mitral valve disease patient. You can easily appreciate the severe thickening of the valve leaflets. Let me go back again to give you all an idea once again, so you can appreciate the severely thickened mitral valve leaflets. Here, both the leaflets are affected. This is a normal patient. There is no thickening of the mitral valve leaflets. And over here, in the abnormal mitral disease patient, there is severe thickening of both the leaflets. This is another view. This is a left apical view. There are different views, when we are doing echocardiographies. So this is the left apical view. This is for those doing echocardiographies. This is a good view to check the anatomy of the mitral valve leaflets. The view is very clear. And over here in this slide, you all can see how thickened the leaflets are. They are severely thickened, and both of them are affected. So these are two different angles or two different views in the echocardiography from where we see the mitral valve. This is the long axis view. This is from the right side compared to this. This is the left apical view. In both these views, you can appreciate the severe thickening of the mitral valve leaflets. So because of the leaflet thickening and the changes in the mitral valve structure, the degenerative changes which go on, there is severe regurgitation which develops. So we call this a leaky valve disease, and there is a severe backflow of blood from the left ventricle to the left atrium, as you all can see in this. So all the mixing of the colors, all the rainbow colors which you see, that is the regurgitant jet. So that is all the rainbow colors which you are seeing here is the blood which is flowing back into the left atrium, which should not in a normal patient. So over a period of time, this is going to cause severe left atrial enlargement. Left atrial enlargement is going to compress the main stem bronchus, and that will lead to all the resultant signs. In the advanced cases, it will also cause congestive heart failure in which there is pulmonary edema, and that becomes a very critical stage. If you don't treat that immediately, the patients, they can collapse. So this is from the echocardiography point of view. For those of us who perform echocardiographies regularly, this is a clip in which through continuous wave Doppler, we measured the velocity of the regurgitant jets of the mitral valve through the mitral valve into the left atrium. So this is just a velocity check. We can also do pressure calculations through Doppler for those of us who are performing echocardiographies. So this is not an echocardiography lecture, but this is just to give you all a brief idea. And performing pressure calculations, it's a very interesting topic. I mean, some point in future, if I get time, then we can have a session on that. You know, how to calculate the different pressures in various chambers in cardiac diseases. Pulmonary hypertension in mitral valve disease happens in the very advanced cases. So how this happens is that as the advancement of mitral valve disease happens, there is increasing left atrial size. So there is more and more mitral regurgitation, and over a period, the left atrial size, it keeps on increasing. Now, because of this increased size of the left atrium, this is going to increase the pressure in pulmonary vein and the artery, and there is a constant remodeling of the pulmonary artery and the vein. And because of this, there is increased and irreversible pulmonary hypertension. So the pulmonary vein is, you can say it goes into the left atrium. So if the pressure in the left atrium is high, and if it is increasing constantly, then the pressure in the pulmonary vein is going to increase, the pressure in the lungs is going to increase, and through the lungs, the pressure in the pulmonary artery is going to increase. So there is a constant remodeling which is happening in the advanced cases of mitral valve disease. This remodeling happens in pulmonary vein and artery, and this leads to a irreversible increased pressure in the pulmonary artery, which we call the pulmonary artery hypertension. Now, what this will do, it is going to cause a tricuspid valve regurgitation. But that tricuspid valve regurgitation is not going to be a primary tricuspid valve regurgitation, because there is no tricuspid valve pathology involved in this. It's only because of the increase in elevated pressure in the pulmonary artery that the pressure in the right heart, it goes beyond a certain limit, and that causes pulmonary artery hypertension, tricuspid regurgitation. The gold standard these days to diagnose pulmonary hypertension is this, that you measure the tricuspid valve insufficiency, you put the color continuous wave Doppler, and you measure the velocity of the regurgitant tricuspid valve jet. If it is more than 3 meters per second, in the absence of a tricuspid valve pathology and in the absence of a pulmonic valve pathology, you can be pretty sure about it, and you can confirm that this is a pulmonary artery hypertension. So this, through an echocardiography, it's very simple to diagnose. If your calculations are accurate, then you can easily diagnose this via echocardiography. Then in mitral valve disease, there are secondary arrhythmias. So because of all the cardiac remodeling which is happening, because of all the volume changes in the atria and the ventricles which happens as a result of this disease, there is myocardial hypoxia, and that may induce all these arrhythmias. Atrial fibrillation, my dear friends, is the most common secondary arrhythmia in mitral valve disease. I see it very, very frequently in cases of mitral valve disease. Sometimes, occasionally, there can be ventricular premature complexes also, which can be visualized. But let me tell you all that VPCs are somehow more commonly seen in dilated cardiomyopathy. Atrial fibrillation is by far the most common arrhythmia. I've discussed this in my previous slides, but let me just show you all a video clip. This is an echo video clip of what happens within the heart when there is atrial fibrillation. So this is a mitral valve disease, and there is a secondary atrial fibrillation which develops. Now in this video clip, you all can very closely watch this, and you can visualize, you all can visualize that the heart rhythm here, though this is not an ECG, this is just a echo video loop, but the heart rhythm here is very irregular. It is very fast and it is very erratic. It is very irregular, right? So this is, when you see this, then suspect atrial fibrillation, go in for an ECG, because if you diagnose atrial fibrillation, there would have to be some rate control medications which you'll have to introduce, because in atrial fibrillation the heart rate, it becomes very high. These are supraventricular tachyarrhythmias, and in all cases of mitral valve disease in which atrial fibrillation develops, the left atrium would be huge. It will become very big. So in this particular video loop also, you can appreciate the left atrium which was big. This is a right long axis view. Again, you all can appreciate the heart rhythm here is very erratic. It is very fast, and you all can visualize this huge left atrium. Mitral valves, of course, they are affected. Both the leaflets in this case, they are affected, and because of this, over a period of time, in this particular case, atrial fibrillation also developed. Of course, I mean, for diagnosing atrial fibrillation, echocardiography is not the gold standard. We have to do an ECG. So this is the same case in which I put some color, and you can see the massive mitral regurgitation. And look at how fast the heart rate here is. Atrial fibrillation secondary to mitral valve disease. This particular slide I had shown to all of you previously as well, and I'll again tell you all the three hallmarks of atrial fibrillation. The three hallmarks would be: hallmark number one, supraventricular tachycardia. So supraventricular tachycardia, because QRS morphology, the morphology of QRS complexes here is normal. So that is why it is supraventricular and not ventricular. And the heart rate, if you measure, it would be very high. So hallmark number one is supraventricular tachycardia. Hallmark number two is the absence of P waves. So in this particular slide, in this particular ECG, there is no P wave before the QRS complex. So this is hallmark number two. And hallmark number three would be that the rhythm would be very, very irregular. So here you can see the rhythm is erratic. It is not regular how it should be. So this atrial fibrillation is an important arrhythmia when we are talking about cardiac conditions in dogs, and that is why I make it a point to run this slide every time I hold a session. Treatment wise, a lot of us, I believe, must be well versed with this. The commonly used treatment protocols include pimobendan, includes ACE inhibitors, includes diuretics, includes nutraceuticals. The use of ACE inhibitors has been controversial because a lot of authors around the world, a lot of them, they don't prefer using ACE inhibitors, whereas a lot of others, they prefer. In my experience, I personally like using it in a lot of these cases of cardiac conditions, in a lot of cases of mitral valve disease, even in dilated cardiomyopathies, because it does have vasodilatory effects and it does reduce the load on the heart. It does reduce the pressures within the chambers of the heart, and because of this, I've seen it. I've seen positive results. That's why I particularly use it in a lot of cases of both mitral valve disease and dilated cardiomyopathy. Diuretics wise, we have a lot of options. We have furosemide, we have torsemide, we have spironolactone, we have furosemide and spironolactone combinations. So there are a lot of options. Of late, I've started using torsemide in a lot of these cases. The advantage of torsemide is that you can even give it once a day. It is longer in the action. It works for a longer duration of time, and it is a highly potent diuretic. So those cases where there has been some resistance, resistance which has developed to furosemide, you can think about torsemide. Or in those cases which are in the very advanced stage of mitral valve disease and dilated cardiomyopathy, again you can think about torsemide. Spironolactone, as I had mentioned earlier as well, it should be used very cautiously along with ACE inhibitors, as both of these will have potassium sparing effects. Pimobendan we all can use from stage B2 onwards. Stage B2, tell you all again that stage B2 is a asymptomatic stage, but on the X-ray there would be some degree of cardiomegaly, or if you do an echocardiography, there would be some degree of left atrial enlargement. So this is that asymptomatic stage, but with some changes in the heart, some degree of cardiomegaly you can see. And from this stage onwards, you can use pimobendan. Secondary atrial fibrillation, if you all see, then you can use lenoxin, you can use diltiazem. If there is pulmonary hypertension, you can use sildenafil. Nutraceuticals, which have carnitine, tauretin, lot of commercially available products are there in the market, and they are also useful. And then in the end, of course, diet plays an important factor, and either you can formulate home meals accordingly, or you can straight away put them on commercially available dog foods. So I've covered mitral valve disease. This was a brief session. You know, there can be a lot of other details which we can cover. But since I needed to cover both these diseases in one lecture, so that's why I've tried to keep it brief. Yet, you know, I included slides so that all of you can get an idea and good insights into what actually goes around in the heart in mitral valve disease. Coming to dilated cardiomyopathy. Dilated cardiomyopathy, as a lot of you must be knowing, it's a disease of the muscles of the heart. It's basically a contractile dysfunction, right? So dilated cardiomyopathy, as the name suggests, the heart is dilated. It's a disease with a big heart. But how that happens is because of the contractile dysfunction, because of the systolic myocardial heart failure. Cardio is heart, myo is muscles, pathy is disease. So it's a heart muscle disease. It's a primary disease of the heart muscles of unknown etiology, but most likely it is genetic. It has been confirmed by research that it is mostly genetic. It can also be secondary to some other things. For example, toxins. Sometimes there can be nutritional deficiencies. There can be endocrinopathies. Endocrinopathies would mean we all have come across hypothyroidism. So hypothyroidism also in the long run affects the cardiac contractility, right? And sometimes in cases of certain infections, again, the contractile dysfunctions develop and it leads to DCM. Dilated cardiomyopathy would mean a progressive ventricular dilatation and the loss of myocardial contractility. These are some of the important breeds which are predisposed to have this problem. Doberman pinschers, highly overrepresented. In Munich University and in Germany, there has been a lot of research on DCM in Dobermans, and they have a lot of publications for this breed. Great Danes, Boxers, Labradors and Golden Retrievers, Saint Bernards, Cocker Spaniels, Mastiffs. These are some of the other commonly affected breeds with DCM. Over here, Labradors and Golden Retrievers in our country, they are highly popular, and because of that, we do come across a lot of DCM cases in the retriever family. The signs of DCM, there is an occult stage. Occult means that occult means the asymptomatic patient, the asymptomatic DCM. Asymptomatic patient, sometimes they come for screening and you see some bit of contractile dysfunction and you see some bit of left atrial and left ventricular enlargement and volume overload, but there are no symptoms. But if you're able to detect this in the occult stage, you can prolong the life, you can better manage it, you can prolong the occult period, right? So occult DCM would have no clinical signs. There can be increased left ventricular dimensions. The left ventricle would be dilated in this. It can happen. There can be increased atrial dimensions. There would be a slightly decreased ability for the heart to contract. Sometimes you see VPCs, ventricular premature complexes. This can last for months and this can last for sometimes years. And if we don't treat it, if we don't monitor this, then the patients, they come in the overt stage, in the symptomatic stage, when they would be more difficult to manage. So this phase ends with the appearance of the first clinical signs. Sometimes there can be sudden death also, which we encounter more specifically in cases of, let's say, German Shepherds, Dobermans. So if you don't monitor the occult DCM stage, if you do not initiate any treatment, it can also lead to sudden death in certain breeds. About 40% of Dobermans experience such death as their first clinical sign. This is a documented research from Germany. Then we come to the overt stage. Overt stage is the clinical phase where there would be congestive heart failure, there can be arrhythmias, there would be respiratory distress, there would be cough. So a lot of these signs which we see in other cardiac conditions would be present. There would be coughing, there would be anorexia, there would be weight loss, there would be arrhythmias, there can be ventricular premature complexes, or there can be supraventricular tachycardia, which happens in atrial fibrillation. So atrial fibrillation and ventricular premature complexes, these are the two most common arrhythmias in both dilated cardiomyopathy as well as mitral valve disease. Syncope, which would mean loss of consciousness and the patient collapses for some time. This generally happens for a few seconds, and after that the patient is almost normal. So syncope, this happens pretty commonly in the advanced stages of DCM. There would be, of course, exercise and activity intolerance. If we talk about the echocardiographic signs, there would be a dilatation and the volume overload of left ventricle and left atrium. So the volume overload is with the blood, of course. There's blood within the heart, and there is volume overload of the blood within the left ventricle and the left atrium, and a secondary eccentric mitral insufficiency. So the mitral insufficiency in cases of DCM is not because of a primary mitral valve pathology. It is secondary to the systolic dysfunction, and the regurgitant jet into the left atrium is going to be eccentric. It is going to be eccentric jet. It is not going to be uniformly spread within the left atrium. Then, of course, there can be death due to congestive heart failure, and this happens suddenly when it happens. There can be, of course, some of the other clinical signs. A very common clinical sign would be abdominal distension and ascites. Because of the involvement of the right heart, there is ascites which develops in a lot of these cases. Coming to the diagnosis, our standard diagnostics which we use to diagnose other cardiac conditions would be applicable here as well. We do X-rays, we do echocardiographies, we do ECGs, we do sometimes cardiac biomarkers, NT-proBNP and cardiac troponins I had discussed previously. So all these would be our diagnostics. In radiographs, it may be normal in the occult stage. So in the occult stage, it may be normal. There may not be any heart enlargement. In the overt stage, in the clinical stage, there would be a pronounced cardiomegaly. There would be a generalized cardiomegaly in a lot of these cases. Then, of course, there would be evidence of congestive heart failure. Congestive heart failure develops when there is pulmonary edema, when there are pleural effusions. So in a lot of these cases, you would see the typical pleural effusion X-ray pattern, or if there is pulmonary edema, you would see the alveolar lung pattern. Abdominal fluid, of course, because of the involvement of the right heart and the right heart enlargement, that causes ascites to develop. Radiographs, of course, they cannot distinguish between different types of heart disease. Many of these diseases will show you an enlarged heart, but then to come to a specific diagnosis, you need to run other tests, in which echocardiography would be the gold standard. ECGs, you would again, ECGs we do to rule out the arrhythmias, and it's important to rule out the arrhythmias because for all these arrhythmias, we need treatment as well. If you don't treat the arrhythmias, that will worsen the cardiac condition. And as I had mentioned, echocardiogram will be a definitive diagnosis. It is the gold standard world over. Cardiac biomarkers for those places, for those practices which don't have the facility for echocardiography or for referring for an echocardiography, cardiac biomarkers are also pretty useful. In this, NT-proBNP and cardiac troponin I measurement is very valuable, and these are accurate biomarkers of heart functioning and cardiac diseases. I had mentioned it previously also, I prefer NT-proBNP and cardiac troponin I, CTNI, over CPK-MB. So NT-proBNP and CTNI are more specific markers compared to CPK-MB. This is just an audio clip of the DCM murmur. So this is a very loud murmur. This is a loud systolic murmur. How the murmur develops? The murmur develops because of the leakage in the mitral valve and sometimes in the tricuspid valve as well. But the important point here is that it's not a primary valve disease. So the leakage is only secondary to the contractile dysfunction. This is a very loud murmur in this clip. Sometimes there are softer murmurs, right? Because so this clip is from a very advanced case of DCM in which there is severe mitral valve regurgitation. But in a lot of other cases, you'll hear a very, very soft murmur, right? So the soft murmur would mean that the intensity of the murmur would be lower than the normal heart sounds, which are S1 and S2. It would be just maybe a grade 1, grade 2 murmur. This is a loud murmur. This is a chest X-ray of a patient who was suffering from dilated cardiomyopathy. The VHS, the vertebral heart score in this, that was high. You can see generalized cardiomegaly. So when you see the X-ray, you can appreciate the gross cardiomegaly in this. Though let me tell you all that the degrees of cardiomegaly can vary from one case to another. It depends on the stage of the disease. But when you see this, you have to run other diagnostics. You have to do your echocardiographies to confirm what kind of a heart condition the animal is suffering from. This is the same patient, but this is a ventrodorsal view. You all can appreciate the severe left heart enlargement, and there is a massive left ventricular enlargement in this. So in this, the vertebral heart score was 11.5. The normal is less than 10.7. And there was severe left heart enlargement with pronounced left ventricular enlargement. And for this particular patient, we went on to do an echocardiography and then confirmed that it was a dilated cardiomyopathy. So the points to consider in all these patients are that it's a large breed dog, it's a left apical murmur, it's a left ventricular enlargement on X-ray, and the rhythm is irregular. So when you see these, you go to the next step, which is echocardiography. And when you do the echocardiography, it would be this kind of a picture which you will see. So if you carefully see, the heart is barely able to contract here. I'll show you a normal clip as well, so that you all can better compare and better appreciate what happens in the DCM. So here the heart is barely able to contract, and because of that, you can see that all the chambers, all the 4 chambers, they are enlarged in size. They are volume overloaded. So this is a normal heart. You can well appreciate how well it is contracting. It is beautifully contracting in this, right? And you compare it to this, it is barely able to contract. So this is a normal, nicely contracting heart. This is a dilated cardiomyopathy. The heart is barely able to contract. This is just another view. This is a short axis view. In this, again, this is a normal heart. It is contracting nicely. And this is a dilated cardiomyopathy. He is barely able to contract. So from different angles, I thought to include, these different views in the presentation, because this will clear your doubts, if any. Right, I play both these together and you can appreciate. This is normal. This is the abnormal enlarged heart, diseased heart with dilated cardiomyopathy. For those of you who are practicing echocardiography and doing it regularly, left atrium to aorta ratio is very important, because in all these cases, be it dilated cardiomyopathy or be it a mitral valve disease, the size of the left atrium tells us about the severity of the disease. So the normal ratio is less than or equal to 1.5. If the left atrium to the aorta ratio is more than that, it will tell you about the enlargement of the left atrium, which is an important parameter when we are studying or diagnosing these cardiac conditions. So in this clip, we had put on some color. We turned on the color flow Doppler, color flow mapping, and you can see the mixing of the colors. You can see the rainbow colors. So that is the tricuspid valve regurgitation happening secondary to the systolic dysfunction, secondary to the contractile failure, right? These are again different views. This is the right long axis view. In the adjacent slide, this is the apical view. This is the left apical view, and through the mitral valve, you can see the eccentric jet, right? So the mixing of the colors, the rainbow colors, you can see the eccentric jet. In a primary mitral valve disease patient, this jet, the regurgitant jet, would be uniformly spread within the left atrium. But in cases of DCM, since it's not a primary mitral valve disease, It's secondary to the contractile dysfunction. So the jet is eccentric. It is a eccentrically directed, sorry, it is a eccentrically directed jet into the left atrium. We come to the arrhythmias and DCM. So this is a ventricular premature complex. The QRS complex is wide. There is no P wave before that. And this is, when you see this is a ventricular premature complex, VPCs, as we say in the short form. And very commonly you will see these in cardiac conditions in dogs, both in mitral valve disease and DCM. Some of these VPCs are more common I've seen in DCM compared to mitral valve disease, but you'll see these in both these cardiac conditions. So in this, a lot of VPCs, as you all can visualize, a lot of VPCs, and the more VPCs you see, the more chances of sudden death, the more chances of a shorter lifespan would be there. These are like red flags. You can communicate to the owners and educate them that these things are going on, and they in that way they will be well versed with a fatal event just in case if it happens. This is an atrial fibrillation. Again, I would not repeat the three hallmarks. By now, you all must be knowing about them. Hallmark number 1, absence of P waves. Hallmark number 2, supraventricular tachycardia. And hallmark number 3, irregular heart rhythm. So this is atrial fibrillation in a case of dilated cardiomyopathy. What causes DCM? There are various factors. The most common one being genetics. It's a genetic heart muscle disease. Sometimes there can be other reasons as well. For example, nutritional deficiencies. Taurine deficiency, DCM, is common in cats, specifically in cats which are on home diets. Taurine deficiency, DCM, also has been reported in the American Cocker Spaniel breed. So there was a research which was conducted on Cocker Spaniels in US, and taurine deficiency DCM was evident, and it happens in the Cocker Spaniel breed. So if there is a Cocker Spaniel which comes to you with an enlarged heart and you do the echo, you come to the conclusion that the contractile functions are affected, and if you come to a conclusion of dilated cardiomyopathy, then think about taurine deficiency DCM. If there is a provision, if there is a facility where you can measure the taurine levels, then do the measurement. If you don't have that provision, then at least start with some nutraceuticals. Tauritine plus, for example, you can start with nutraceuticals if you don't have that provision. In cases of toxemia, in cases of chemotherapy, doxorubicin chemotherapy, sometimes DCM can develop. Endocrinal diseases are there, like hypothyroidism, which I had mentioned. It can lead to, over a long period of time, it can lead to contractile dysfunction because it does affect the heart systolic functions to some extent. If there is an infection or inflammation, as in case of myocarditis, again, it can cause systolic myocardial heart failure. And then in the end, if there are arrhythmias, if there is a chronic rapid heart rate, it would directly and indirectly affect the heart muscles, which can lead to dilated cardiomyopathy. As far as the prevention and treatment is concerned, well, in prevention, you have to know what breeds are mostly affected. If you know about the breed predispositions, then you can do your screening, you can do the monitoring in the occult stages and prevent it from developing, or at least prolonging the occult phase. As far as the treatment is concerned, ACE inhibitors, pemobendin, nutraceuticals, diuretics, omega fatty acids, these are the commonly used drugs to treat this condition of dilated cardiomyopathy in dogs. If there are arrhythmias, then of course you have to treat them also accordingly. If there is atrial fibrillation, you can think about digoxin, you can think about diltiazem. If there are VPCs, if there are ventricular premature beats, depending on how many VPCs you see, depending on that, you can add drugs like sotalol. So the takeaway message for all of you is subjective evaluation. Subjective evaluation would be for those who are doing the echocardiographies, that the first step would be that you don't straight away jump to a conclusion. You look at the video loop. If you're doing x-rays, you look at it carefully. Don't immediately jump to conclusion. Subjective evaluation would be the key. You just have to obtain the perfect view if you are doing echocardiography, and you have to just observe. My dear friends, your eyes can tell you a lot of things. Carefully observe the contractility, the valve structure, any irregularity in the heart rhythm, any chamber enlargement or volume overload which you see. You carefully look at the wall thickness. So grossly or subjectively, when you see, your eyes can tell you a lot of things. Put on the color Doppler. You look for any valve insufficiencies. So these are some key takeaway messages from my presentation. In the end, I would like to conclude by showing these commonly used cardiac drugs. These are commonly available now. We have pimotone, which is pimobendan. We have Toretine Plus, which is a nutraceutical containing taurine, carnitine, and a lot of other useful ingredients. We have benazepril in the form of benzavet and ricarpiol wet in the form of furosemide oral suspension. So I come to the end of my presentation. I would like to thank all of you for having the patience, and now we can take on any questions. If there are any doubts, feel free to discuss.